All right, so we'll just give it a few minutes and have everyone trickle in. And then as they start to trickle in, I'll go ahead and just hand it over to you.
Sounds good.
All right, so any fun plans for the holidays for yourself, Dr. Pollack?
Yeah, I'm going to go on a little vacation down to Florida, so it should be fun.
Very nice,
Yeah.
warm weather. Better it's warmer than Virginia, right?
Yeah, although right now it's like it's almost 60 today, so yeah, it's not really much of a December. So yeah, how about yourself?
I mean, I honestly feel that. I mean, I'm in California, so California is like perpetual summer, even in the winters.
Mm-hmm.
I think the coldest it's gotten here so far has been like 40 degrees, but that's only been for like a few hours in the morning.
And then it gets nice. Are you in Southern or Northern California? I forget.
SoCal, yeah, SoCal.
Cool. Yeah, my friends, they've moved back here, but like years ago they moved there, and I think we went out to visit them in June, and that's when I learned about the June gloom. And I was like,
yeah,
she's like, well, it's actually kind of not that nice in June. It's just kind of gray, and it's like, it's so strange.
All right, well, welcome everyone. I see we have a few people in. We're just giving it a few more minutes just to have everyone else trickle in. But in the meantime, if people that are already are on with us, you want to go ahead and just maybe share where you're watching from today, or if you have any holiday plans coming up or anything you're looking forward to in the next couple of months, or well, new year, I shouldn't say.
Oh, wow.
Amsterdam.
Amsterdam.
Wow, okay. That's amazing. I have not been to Amsterdam. My friend studied abroad there, and I was super jealous. I did not get to do that in college.
Don't worry, there's more time to get there.
Oh, there is, yeah.
That was one of the last places I went before the pandemic stopped everything for a conference near there. And then I got to spend a few days in Amsterdam and go to the museums. It was really nice.
That'd be amazing. All right, so I'll go ahead and get us started here. And then as more people trickle in, they'll just be able to kind of catch up a little bit with us. So my name is Joe, and I work for the Riverside Medical Clinic Charitable Foundation. We are a nonprofit located in Riverside, California, and our foundation's mission is just to really improve the lives and well-being of the individuals in our local communities that's here, so in inland Southern California. And let me start off by introducing our guest speaker today, Dr. Anna Pollack. So Dr. Anna Pollack's research focuses on the relationship between environmental chemical exposures and fertility, pregnancy, and overall gynecological health. Critical to the understanding of these endpoints, she investigates biological mechanisms underlying these processes, such as biomarkers of oxidative stress, inflammation, and endocrine disruption. Dr. Pollack's research is based on the theory of critical windows of exposure, which emphasizes that the timing of exposures can result in permanent changes. Dr. Pollack's research also addresses disparities in exposure, which stem from environmental and occupational sources. And Dr. Pollack is an associate professor and researcher at George Mason University. And with that, I will go ahead and give it to you, Dr. Pollack.
Super. Thanks so much for that kind intro. And thanks so much for inviting me to speak to your group. It's a pleasure to be here. And I encourage folks who are on the call to ask questions through the chat, and there'll be time for discussion or questions at the end. And so I guess I'll go ahead and share my screen. Oops, that's just the options. There we go. All right. And so I'm going to talk about this. It's kind of a long title about this thing called the adipose to serum ratio of persistent endocrine disrupting chemicals and endometriosis. And first, before I kind of get into that, I can tell you a little bit about myself. I was a bio major in undergrad, was interested in public health, so got an MPH with a concentration in environmental and occupational health, and thought probably that would be as far as I went, because I thought, to be honest, that it would be very hard to come up with a research question that hadn't been answered yet. And through working a little bit with my MPH, I found that really not to be the case, especially in the field of gynecological disease and endocrine disrupting chemicals. There's a lot that we don't know yet that we're trying to learn more about. And so then I went ahead and got my PhD in environmental epidemiology from Hopkins, and did a postdoc at the National Institute of Child Health and Human Development, where I kind of layered on additional reproductive epidemiology training. And then I've been at Mason since 2013. And Mason is the largest public university in Virginia. It's located in the suburbs of DC. And we have an undergrad degree, master's degree, and a brand new PhD degree. So that's a little bit about me and where I am as by way of background. And in terms of an overview of what I'm going to speak about, I'm going to talk just a little bit about endometriosis. That may be a little bit of review for this audience. I'll talk about persistent endocrine disrupting chemicals, why I'm interested in them, why and how we're exposed to them. Describe this adipose to serum ratio of exposure to endocrine disrupting chemicals. And then I'll describe for this particular project the methods, results, and some of my next step for my work. So endometriosis is characterized by endometrial glands and stroma that grow outside the uterus. And these figures are from the original paper by Sampson from 1927, wherein he posited this theory, which still remains one of the prevailing theories of the etiology of endometriosis, which is that of retrograde menstruation. There's some other theories of the etiology, including direct invasion of the myometrium by mucosa, and then additionally, some links to immune system issues. And so I just have to say, when I was in my training and I found out about that this was the prevailing predominant theory of endometriosis, that really sparked my curiosity. And why did it spark my curiosity? Well, one, because so retrograde menstruation, and for those of you who aren't familiar with that, it is a process by which, rather than menses leaving the uterus through the vagina, it could go out through the fallopian tubes and then get lodged inside the body cavity. So that is, it's estimated, happens in about 90% of people with uteruses. And endometriosis, the prevalence of which is between, say, 6 to 11% in the general population, is much less frequent than the occurrence of retrograde menstruation. So that kind of sparked my interest in endometriosis, because of this kind of discrepancy where this process happens in the majority of population, but the condition clearly doesn't happen in the majority of the population. So as I was saying, the prevalence of endometriosis between 6 to 11%, it comes with a variety of symptoms that include dysmenorrhea or painful periods. And I know that the audience is kind of, my understanding anyway, is that it's divided between maybe some OBGYN folks and some patient populations. So, you know, some of this may be familiar to you already. Bleeding between periods, non-menstrual pelvic pain, dyspareunia or painful intercourse, infertility, adhesions, and notably, the severity of symptoms doesn't always correlate with the severity of the disease of endometriosis. And so that's another kind of component of endometriosis that really drew my attention and caused me to get interested in it. In terms of the established risk factors for endometriosis, thus far we have being of reproductive age, having a family history of endo, which is kind of an entangled and complicated risk factor, because one, how common is it for families to talk about gynecologic disease? Maybe that varies within families, but probably not universal. And also the challenges of diagnosis make that a component where access to care maybe comes into understanding of that family history. And then being nulliparous is another component. And endometriosis is diagnosed through laparoscopic or laparotomy surgery. It takes between 5 to 7 years until, on average, individuals receive a diagnosis. And this is for a variety of reasons, but as you might imagine, getting to the point where a patient is going to undergo surgery for this diagnosis, perhaps there's components where the severity of the symptoms is one factor, access to care, and belief in someone's credibility of their symptoms, which we know kind of tends to track more with white individuals and less with Black individuals and other individuals of color. So this does complicate epidemiologic studies of endometriosis. Researchers can get around this by choosing a couple of different options. They may undergo or use self-report from individuals, or perhaps a self-report of a physician's diagnosis, or as I'll describe with this study in a bit, there are surgical recruitment approaches where an individual is presenting for laparoscopic surgery for any indication are approached about enrollment in a study. And so that's what the study that I'll describe shortly did use. And this is a component that also really interests me, and I think there's more to be done on this point. This recent article by Boji et al. I apologize if you all can hear that. I didn't know that our basement was going to be worked on today. Is that distracting? No, you guys are okay with it? Okay, there's just some like loud banging. I didn't know that was scheduled. I would have gone into the office. Anywho, so Black women are less likely to be diagnosed with endometriosis, and some of that is for the reasons that I've described. And I think there needs to be more work to understand what's behind that as well. In terms of why am I interested in endocrine disrupting chemicals in relation to endometriosis, we know that endometriotic tissue needs estradiol and hormones in order to grow and generate. And so, there's various sources of hormones within the hormonal milieu, and that includes adipose tissue, which will come into play as I'm describing the adipose to serum ratio, endometriosis itself, and the hypothalamic pituitary gonadal axis, specifically the ovary as well. And there's been some really nice review studies that have highlighted that endocrine disrupting chemicals may play a role in the risk of endometriosis and uterine fibroids. Now, this work is really important and indicates that it's possible that endocrine disrupting chemicals, because these gynecologic diseases rely on reproductive hormones for their formation, for their continuing causing of symptoms, that it's possible that chemicals which disrupt the body's endogenous hormonal balance may play a role in the risk of endometriosis. And I wanted to spend some time talking about and describing the major classes of chemicals that I'm going to talk about in this talk today. And so there's 3 different classes. The first of which are polychlorinated biphenyls, or PCBs. PCBs are banned completely, but are continue to be persistent in the environment. They originally were used as, aspects to lubricate metal in industrial processes, and so in electrical transformers and things like that. And now near where they were produced, they can be a component of pollution in the surrounding environment. In addition to that, because they're in kind of the soil and water, exposure to PCBs, the most common route that humans are exposed is via our diet and through consumption of kind of higher order predators, so and also fattier foods. And the second class of chemicals that I'm going to talk about are polybrominated diphenyl ethers, or PBDEs. And PBDEs are a chemical that acts as a flame retardant, and they are added to most fabrics that are found in homes. Certain states, such as California, has kind of led the way on phasing these chemicals out, but because people aren't purchasing new furniture all the time, it's safe to say that these chemicals are components in house dust, and because they're not bound to the surfaces that they're added to, they can off gas from that foam, and then individuals can be exposed through just kind of being in their home, through eating and consumption of dust and things like that. The other class of chemicals that I'm going to talk about today are organochlorine pesticides, or OCPs. And OCPs are a group of pesticides that have been banned for decades, but similar to PCBs, to which we're exposed kind of continuously at low levels through our diet, largely. The OCPs include, many people are familiar with DDT from the book Silent Spring. So that's one chemical within the group of OCPs. So I hope that provides kind of an umbrella overview to the 3 main groups of chemicals that I'm going to talk about today. And this figure from the National Health and Nutrition Examination Survey, or NHANES data, by Shojan et al., highlights that there is, in fact, continuous exposure to these chemicals, despite, as I was saying, that they have been banned largely for many years. So you can see the concentrations in blood of PBDEs is quite a bit higher than that of PCBs as we move down the slide to see PCB concentration. And moreover, that the concentration of PCBs really does track with age, in that older individuals have higher concentrations of PCBs. So we can say that these bioaccumulate, and all of these chemicals are lipophilic, so they're stored in adipose tissue. And that trend is similar with DDE, which again is the major metabolite of DDT. And so this is the representative of the organochlorine pesticide component. And in terms of biomarkers of exposure, I'm just going to move over here because I feel like it's just a little loud right underneath me. Let me know if there's any connectivity issues as I scoot over away from the hammering, and I apologize about that. So traditionally in epidemiologic studies, we measure things in these types of chemicals in blood and either in serum or plasma. These chemicals are not really great measured in urine, but that's another kind of biospecimen in which it may be possible to measure some types of chemicals that I'm interested in, not these in particular. And what I was just mentioning in the previous slide, especially true for PCBs, is that these chemicals bioaccumulate and are stored in adipose tissue. So if you look over to the panel on the right, you can see that persistent organic pollutants, that the exposure to them may indicate something different, whether or not someone is gaining adipose tissue or losing adipose tissue, or whether someone is exposed and has a lot of adipose tissue where it can distribute quickly. Conversely, if someone was exposed and then is losing adipose tissue, this can serve as a source of continuous exposure because the PCBs or other persistent organic pollutants are being released from that adipose tissue as fat loss occurs. And this was described really nicely in this Lamerle et al. Article. And so just to get into that a little bit more, because, and sorry, before I go into that, I just wanted to mention that this is also of interest to me because the handful of studies that are available on anthropometry and endometriosis do seem to support that individuals with endometriosis tend to track lean. So they tend to be slightly lower body mass index than individuals without endometriosis. So I think that's an added component where if we're thinking about these lipophilic chemicals, like trying to understand and interpret what do these levels in blood mean as compared to some of the other target tissue chemicals. So for example, I'll walk you through this scenario 2, where an individual has their persistent organic pollutant level measured at risk at midlife, and then undergoes weight loss. And then that individual's kind of chemical burden is perhaps even higher risk. And so just thinking about the trajectory of someone's anthropometry over the course of their life, I think is an additional component that I want to think about. And similarly to, I know this figure is a little bit busy and slightly small, but this is from Ali et al. In 2017. And it just kind of underscores the point that if someone receives, say, individuals receive the same level of exposure to a persistent organic pollutant. And by persistent organic pollutant, I'm including those 3 chemical classes that I had mentioned before, the PCBs, PBDEs, and organochlorine pesticides, or OCPs. And if an individual has a greater store or source of adipose tissue, then perhaps at the time of that exposure, more of the chemicals are sequestered directly to the adipose tissue and less directly to the critical target organs. Whereas if someone is more lean, then perhaps this chemical exposure may be, in fact, more evenly divided between adipose tissue and the kind of target organs. And here I'm thinking about target organs of the endometrial tissue, and put a pin in that, and I'll talk about it more at the end, but not to belabor this point too much, but I don't know, I just find that really interesting about the different components of exposure to these chemicals. So one other component I think that has always struck me is that persistent organic pollutants are often treated kind of like a group that behave the same. And when in fact, they have varying levels of lipophilicity. And lipophilicity just means, if you remember like phospholipid bilayer and biology, things like that, it just means how much do they prefer to go into fatty adipose tissue versus like it's a measure of their polarity essentially. So this figure on the right shows a couple of different relationships between tissue concentrations and different food web animals for different chemicals, specifically one PCB congener, PCB 153, and beta hexachlorocyclohexane, which is a member of the organochlorine pesticides. And so what this is showing is that in the oceanic or piscivorous food web, that PCB 153 does just what I had said initially when I was describing these chemicals. It bioaccumulates as you move up the trophic level. But beta HCH, beta hexachlorocyclohexane, doesn't do that at all in the ocean. It just stays at the same level. Now, both of these are persistent organic pollutants, but they're acting differently in this environment. In the terrestrial food web, they do act more similarly. And I want to point out that PCB 153 has a very high octanol water partition coefficient, or KOW, whereas beta HCH has a very low octanol water partition coefficient. And so treating all of these chemicals as if they have the same properties is also, I guess I would say we should think a little bit more about that and not treat them all as though they're identical. So moving on into how I got interested in this new way of thinking about chemical exposures. I read this article by Ploteau et al. A few years ago and was really interested in it. So this was a study in French women with endometriosis. And they were measuring persistent organic pollutants in serum, omental, and parietal adipose tissue, and looking at how these chemicals in different fat tissues related to the levels in serum among these women who all had endometriosis. And ultimately, they found that that these levels may have been associated with endometriosis, but because of their sample only including women with endometriosis, they proposed that additional work was needed. So my hypothesis going into this project was that considering both the adipose level and the serum level ratio of persistent organic pollutants would provide insight into the dynamic of that chemical beyond just looking at the chemical in serum or the chemical in adipose tissue alone. Because of these dynamics that I've talked about, where weight trajectory changes, where someone's adiposity when they're exposed affects where that chemical goes in the individual. Secondly, my hypothesis was that the adipose to serum ratio of persistent organic pollutants will be associated with endometriosis. and that chemical mixtures of persistent organic pollutants, particularly estrogenic chemicals, will be associated with endometriosis. And to examine these hypotheses, I used data from the Endo study, from the operative cohort of the Endo study. So all 495 women in this study underwent laparoscopic surgery for some indication. Not all of them was because of suspected endometriosis. The women were aged between 18 and 44, and they were recruited from 14 clinics between 2007 and 2009 in San Francisco and Salt Lake City, Utah, in the US. The eligibility criteria were that the participants could have had no history of endometriosis, not used injectable hormone treatments for 2 years, and could not have been breastfeeding for the prior 6 months, and also could have had no cancer history. So the Endo study conducted really a lot of data collection. The individuals had a baseline interview about 2 months before surgery. And importantly, as I was saying, that some epidemiologic studies are challenged by ascertaining whether someone really is diagnosed with endometriosis. So this study did have that gold standard of endometriosis diagnosis, incident, surgically visualized endometriosis. And the study collected blood specimens from which to measure these 3 groups of persistent organic pollutants. And also, as the surgeons felt it was possible and would not interfere with patient care, they also collected 1 to 5 grams of omental fat during surgery. And those samples were also analyzed for chemical levels. The POPS analysis was done using high resolution GC mass spec, quantified at the Wadsworth lab by really expert groups in this, and had multiple blanks in each batch. There were 12 organochlorine pesticides that were measured. Those are listed here: 6 PBDE congeners, 6 anti-estrogenic congeners, and 7 estrogenic PCB congeners. I used the criteria developed by Wolf et al. From 1997 to classify the PCBs with respect to their estrogenicity or not. And in terms of our statistical analysis, we looked at the demographics of individuals, calculated the adipose to serum ratio by dividing the wet weight adipose level of that chemical. So let's just say PCB 153, we would divide the level of adipose PCB 153 by the level in serum for that individual to come up with this new measure of adipose to serum ratio. And then we looked at correlations, distributions between chemicals and across biological matrices. So we compared serum, adipose, and adipose to serum ratio. In addition, we conducted logistic regression for the odds of endometriosis diagnosis, and we adjusted for these confounding factors: age, body mass index, serum cotinine as a marker of smoking, a biomarker of smoking, breastfeeding, conditional on parity. And then we also conducted some mixtures models to look at not just one chemical at a time, but groups of chemicals. So we conducted Bayesian hierarchical models, and we looked at classes of chemicals compared to serum using those methods. And then we also used Bayesian kernel machine regression to flexibly model potential interactions within classes of chemicals. So I'll go through those results next. First, I'll show you a little bit about the participants' characteristics. Individuals without endometriosis were slightly older, 34 years compared to 32. As I was saying earlier, it held true in this sample as well that individuals with endometriosis had a slightly lower BMI than those without. Also, their average parity for that group with endometriosis was lower, indicating that, as I had said earlier, nulliparity is a risk factor for endometriosis. So they were less of those participants had babies. And then there were some differences in serum lipids, with women with endometriosis having lower levels of serum lipids than those without. In terms of education, it was a fairly highly educated cohort overall, and there weren't very large differences in terms of the education of the population. In terms of smoking, more participants without endometriosis smoked, and participants with endometriosis were less likely to have smoked. And this is one of these kind of strange things about smoking and endometriosis. It seems like, although smoking is certainly not good for you, that studies seem to find that smoking is associated with a lower risk of endometriosis. So that is yet another puzzle about an endo and smoking. In terms of ever having breastfed, women with endometriosis were slightly less likely to ever have breastfed an infant than those without. And this table is a little bit, it's a little bit a lot. There's a lot going on, but I just wanted to draw your attention to a few of these results, just to kind of clarify the various things that I've been talking about thus far. So these are the different chemicals and their adipose to serum ratios, the median levels of their adipose to serum ratios for the total cohort, for those with endometriosis and those without endometriosis. And this second column shows the log KOW, and remember that's the octanol to water partition coefficient. And first of all, just remember that these chemicals are all treated as persistent organic pollutants. They all are lipophilic to the same amount. But if you note, kind of the lowest adipose to serum ratio is here for the estrogenic PCBs, specifically congener 49 and 52. You can see the median adipose to serum ratios are well below 1. And these congeners have a log KOW of around 6. In contrast, some much higher levels are noted for oxychlordane and para-DDE, which is the main metabolite of DDT. Remember, that's a legacy insecticide that's no longer used. So, and those have a similar octanol water partition coefficient. So I guess that also tells that the octanol water partition coefficient is not the be all and end all, and that there can be markedly different levels of adipose to serum ratios for these chemicals. Then I also wanted to show just the highest octanol water partition coefficient for PBDE 209 at 10, and then the lowest for beta and gamma HCH at just under 4. Next, we looked at the correlation coefficients for serum for these chemicals for PCBs, the correlation coefficients between among these chemicals in adipose tissue, and then the correlations of the adipose to serum ratio, remember, which is just adipose divided by serum. So I'll show you a couple of these tables or these figures kind of showing that by and large, the levels of correlation do track across different biospecimen compartments, but not completely. So you can see, say here, for the correlation between PCB 187 and PCB 77, it's quite a bit stronger in adipose tissue than it is in serum. And so some of those correlation differences are just going to kind of show briefly in the next few slides. So also for the anti-estrogenic PCBs and for the organochlorine pesticides, there's a few of those kind of differences in correlation between chemicals, whether they're in different biospecimens. So that kind of underscored why I thought, well, maybe looking at these chemicals, which because of all these other reasons, looking at the adipose to serum ratio may provide new insight into whether these particular groups of chemicals are associated with endometriosis. And then we created some correlation heat maps between adipose, serum, and the adipose to serum ratios. And this kind of just allows you to see how, for example, in this top row here on the left, for the estrogenic PCBs, serum and adipose are kind of weakly positively correlated, with darker red indicating a stronger positive correlation and darker blue indicating a stronger negative correlation. Now remember, because the adipose to serum ratio is the ratio of adipose over serum, we forced serum and the ASR to have a negative correlation, and we basically forced adipose and the adipose to serum ratio to have a positive correlation. So that's kind of by design of how we made this measure. And next, I'm going to show you some of our results for, and what we're looking at here is the odds ratios for endometriosis per standard deviation increase in chemical concentrations. And this is comparing serum in the green box and whiskers, adipose in the red, and the adipose to serum ratio in the purple. And so I'll draw your attention here again to the estrogenic PCBs, PCB 49 and 52, as well as 201, where you can see for serum, there's not an association. So again, because we're looking at an odds ratio, the null value is 1. And so anything that is close to 1 or where the confidence interval crosses 1, we would say is not associated with endometriosis. Kind of just briefly, so that we're all on the same page about how we're thinking about this. But for adipose and the adipose to serum ratio, we're finding that for those same chemicals, there are associations with an increased odds of endometriosis. And similarly as well for hexachlorocyclohexane for the OC pesticides, where you're seeing this stark difference. We're looking at these chemicals in blood, it almost looks as if there's a reduced risk of odds of endometriosis, similarly for 201, whereas for the adipose level concentration and the adipose to serum ratio, there's an increased odds of endometriosis. And these are from our logistic regression models. For the polybrominated diphenyl ethers, PBDEs, we really didn't see those striking differences by biospecimen. And we also kind of the story there is not much going on. And then also for anti-estrogenic PCBs, by and large, not much going on across the class here, regardless of the biospecimen, serum, adipose, or ASR. Next, we conducted Bayesian hierarchical model averaging to look at the percent change in odds ratios of endometriosis across these chemical groups. And here, a 0% change is considering measuring it in serum. And then we are comparing adipose to our results in serum, and we're comparing adipose to serum ratio in purple to the results for serum for that group overall. So it's a way to effectively say, for this group and overall for all of the chemicals, did measuring these chemicals in adipose or adipose to serum ratio, were those findings similar to the findings for serum? And what we're finding, what our results are showing, is that measuring these chemicals in adipose tissue or looking at the adipose to serum ratio, actually, you're finding a 15 to 20% stronger association compared to looking at serum only. And that association, or that was even stronger for estrogenic PCBs with, about a 30 to 35% stronger association for adipose or the ASR. And then again, for PBDEs, really no difference. It didn't matter what biospecimen we were measuring this in, but for OCPs and a little bit for antiestrogenic PCBs, the adipose to serum ratio was had a stronger association. Next, we used Bayesian kernel machine regression and these models estimate changes in latent health or here risk of endometriosis for each 5% increase in the whole mixture for that class. So here, this picture of estrogenic PCBs in the figure is considering all of the estrogenic PCBs together in a model. And what we did was set the reference at the 25th percentile. So that's what we're comparing to. So we're comparing that mixture in either serum, adipose tissue, or the adipose to serum ratio to the 25th percentile. And then here at the 75th percentile, what we're showing is that for adipose levels or adipose to serum levels, that there is an increased risk in endometriosis for the group of PCBs that are considered estrogenic, but not when we measure them in serum. So those same chemicals in serum, there's no association. So I think that is kind of one of the key findings from our study. Again, for antiestrogenic PCBs and PBDEs, not much going on. And for organochlorine pesticides, some indication that the mixture of organochlorine pesticides in adipose and the ASR were associated with an increased risk of endometriosis. We did some sensitivity analyses to kind of better understand our results and see how sensitive they were to some of our underlying assumptions. And what we did was there's a way of adjusting for lipids. And so we're aware that there's different approaches to doing this. And so we did it both ways and found that our findings were really robust to lipid adjustment, no differences. And then we also stratified by obesity in the endo study. And for many of the chemicals, there weren't big differences, although our numbers got smaller. So our point estimates did jump around. Salmon colored is not obese and teal is obese here. We did find for estrogenic PCBs and antiestrogenic PCBs some indication that maybe for obese individuals, for the adipose to serum ratio, that maybe there were some additional PCBs that were associated with endometriosis when looking at this. So I would look for additional studies that have kind of larger sample size in order to corroborate that. I also looked at recent weight change and didn't find much there. So in conclusion, the adipose to serum ratio of beta hexachlorocyclohexane and gamma HCH and PCB 49, 201 were associated with endometriosis. And moreover, contrary to my hypothesis, associations for the adipose to serum ratio were really quite similar to those that we saw already for the adipose concentrations. They were, however, a little bit stronger, but they were overall showing a similar story. This was the first study to evaluate mixtures of chemicals in serum adipose and adipose to serum ratio for persistent organic pollutants with endometriosis. And we did find that estrogenic PCBs were fairly consistently associated with endometriosis using those mixtures models. So there are some lingering questions that I'm looking forward to working on next. Does serum really reflect the steady state of adipose tissue levels? And is this all just an issue of measurement error where we're not quite measuring the chemical that we're interested in at the target tissue? So if the target tissue is of interest, then really looking at the endometrium itself and even endometriosis implants would be of interest. And that's actually for my next study. I have funding from NIEHS in order to look at that, chemical measurements at the target tissue. And I'll be looking at chemicals called PFAS, per and polyfluoroalkyl substances. And again, these persistent organic pollutants. And I'll be also together with a PhD student characterizing symptoms of endometriosis and chemical exposures and treatment outcomes among Black women with endometriosis. I'd like to acknowledge the funding that made this work possible from the Endometriosis Foundation of America, as well as funding for the endo study. Oh, and also funding from NIEHS for my R01, as well as my fabulous collaborators, Jenna Krall at GMU, Jermaine Buck-Lewis, also at GMU, who was the original PI of the endo study, and Carintha Chalam-Cannon, who's at NYU, and Zen Chen at NICHD, who's the current PI of the endo study. So thank you so much for your attention. I'd be happy to take any questions. I'm gonna go ahead and try and stop sharing the slides. There we go.
Awesome. I actually had a question come in earlier. So it's kind of having to do with the catabolic process of beta oxidation with fatty acids. So like if someone would have been going through like almost like a ketosis in which they're sort of catabolizing free fatty acids, would that have anything to do with maybe increasing the exposure to these chemicals in maybe like their serum levels as they're now going to be like free flowing?
I think so. I think, yeah, I think that's exactly as you described. We would think that they might get mobilized from adipose tissue into serum with that happening. Exactly. And some studies have looked at this kind of like in smaller study sizes, just that are interested in, I guess the more of the literature on it that I've found is in kind of the obesogenic chemicals thinking, because some of these chemicals are also suspected of playing some role in the obesity epidemic. And so for that, that's like a whole other area that people are working in.
Anyone else have any questions or comments you'd like to share before we go ahead and end it? I know we kind of went a little bit later, but that was my boss, a little bit late. No, I don't think so. All right, so I will leave it. Well, we have a hand raise. Let me see. For someone here. Let's see. I'm not sure if she was trying to ask a question or not. But this will be posted on our YouTube channel for anyone that does not get a chance to see it live. And I will go ahead and also drop more information on the studies as well that Dr. Pollack is working on in the description for our YouTube videos and stuff like that. And if you're okay with it, would it be okay if I go ahead and leave like your GMU email address for individuals to reach out if they do have any questions?
Yes, I was just putting it in the chat. I was going to say, please feel free to reach out to me with any follow-up questions. I'd be happy to chat one-on-one on that. Thanks again so much for the invitation. I appreciate it.
Awesome. Thank you for spending the hour of your day with us. And thank you for everyone here that attended as well. And with that, we'll go ahead and we'll end it. All right. Thank you.
Thanks.